So, hello everyone again. So the session is about lifetime management of AF, when and how to propose left atrial appendage closure. I'm very happy to co-chair with Tom Potter, and we have panelists for this session. So Jens Erik, you can come to join us with Jan Kovac and Sergio Berti. You can stay at your place or come if you want, as you are speakers of the session. So I'm really happy to introduce my co-moderator, Tom de Potter. Your presentation is long-term management of AF patients from early symptoms through rhythm management and stroke prevention. Thank you.
Thank you very much, Philippe, and hello everybody. So very ambitious scope of the title. We won't cover all of that in detail, of course, and I will try to show you some high-level ideas and insights that were published in the last 12 months, and two very important and insightful papers if you're keen on learning more about management of AFib in general. Were published in the last year. We published the ERA consensus document on the right, and we published, of course, the 2024 ESC AFib management guidelines. Key new aspects of these guidelines are the patient-centered and integrated care for our AFib patients. The care paradigm, which starts with optimization of risk factors. That's a bit beyond the scope of this talk. If you're keen on using acronyms, you can try to remember head to toes. But the C of comorbidity management falls a bit outside of the scope of this talk, but I put it in anyway because it's important to remember that the care paradigm starts by mentioning that its components, and especially the rate control and stroke prevention aspects, apply nearly universally to all patients with atrial fibrillation, regardless of where they are in their stage of the disease. And before we move to the stroke prevention aspect, I want to share a few insights on the other management of AFib, which is obviously ablation. And also for ablation, the guidelines offer a few new insights. Particularly, first-line ablation is an accepted concept now in the ESC guidelines. First-line ablation, meaning that for paroxysmal atrial fibrillation patients, after shared decision-making, which is a quite central element of the guidelines, catheter ablation or pharmacological rhythm control have an equivalent class 1 indication for the paroxysmal atrial fibrillation patients on the left, and on the right for the persistent atrial fibrillation patients, catheter ablation has a class 1 indication in those patients where antiarrhythmic drugs have failed. This is these pathways in detail, again, a bit beyond the scope of this particular talk, but for paroxysmal atrial fibrillation patients, as well as for persistent atrial fibrillation patients, you can see a class 1 indication for catheter ablation. And this is a new insight which is probably bound to evolve even further, which is that rhythm control can truly improve the prognosis of our AFib patients. And rhythm control as a strategy is indeed advised within 12 months of diagnosis, largely based on the results of the ESC AF2024 trial, which randomized patients to either usual care or early intervention. Early intervention, not necessarily ablation, mind you. Early intervention defined as ablation or rhythm control strategy. And the ESC AF2024 trial was stopped early for achieving its efficacy endpoint. There is a significant reduction in the primary endpoint of death, stroke, or hospitalization for the early rhythm control group. And the reason I think this will evolve even further is, of course, because of the development of post-field ablation, which has revolutionized the field of atrial fibrillation ablation. Post-field ablation, for those of you unfamiliar, is a ablation modality which is not thermal, which damages the cells through electrical current. It's called non-thermal ablation, or also tissue selective ablation, because it has the unique characteristic of being able to damage the myocytes without causing collateral damage to, for example, the phrenic nerve or the esophagus. And the reason we're all excited as electrophysiologists is not hard to explain to you. This is a image, a photo of a pulmonary vein potential. You see here a circular catheter in the vein recording pulmonary vein potentials, and this is the effect of a single ablation, a single pulsed field impulse, and you see it obliterates the potentials. And the reason I show this is because I truly believe that what we have in the guidelines now, which is a fairly enthusiastic but still restricted recommendation for ablation in selected groups, for example, implementation of a rhythm control strategy within 12 months in selected patients at risk of thromboembolic events is a class 2A indication, or in those patients with reduced ejection fraction and a high probability of tachycardiomyopathy, which is obviously a class 1 indication. I believe this will grow stronger and stronger, and this is due to the simple fact that the ablation I just showed you, pulsed field ablation, is so universally easy to implement in new labs and frees operators from significant concerns which were present in the past. The more important topic for this conference, and a very important part of the guidelines, is of course the association of atrial fibrillation with stroke. The association in itself is not new, of course. Significant proportion of AFib patients will experience stroke. AFib in itself is a very important contributor to the incidence of ischemic strokes, and obviously atrial fibrillation significantly increases your risk of experiencing stroke. In the guidelines, the key new aspect for stroke prevention are the risk scoring scheme, which changed, which is probably the most publicized change. It's a minor change in terms of impact, but we now speak of the CHA2DS2-VA score because of the female sex risk modifier actually does not apply in younger patients, and we felt it created more confusion than it solved issues. So it is no longer promoted in the 2024 guidelines, and the guidelines actually say if you have a locally validated system, or even better, if you manage to come up with individualized risk profiling, that is even far preferred. Importantly in the guidelines is the concept of periodic reassessment, of course, once stroke risk is not static. It's a dynamic concept which needs to be reassessed. An important new aspect in the guidelines also is the concept of stroke despite oral anticoagulation, for which a clear lack of benefit has been shown of using antiplatelets. This is not recommended. There is a warning against routine DOAC switching, which typically does not free the patient from new strokes, which is typically not the cause of the stroke on OAC, and explores, of course, the possibility of LAA clipping or surgical exclusion based on surgical results. And as many of you know, the LAAC trial has been initiated, will roll out in Europe. It has started already in Canada and the US, and will inform us of the feasibility of percutaneous closure in this patient population. Based on LAAC, the guidelines recommend LAA exclusion in all the concomitant surgery procedures. And an interesting aspect which is incompletely understood, I think, is the concept of subclinical atrial fibrillation. Subclinical atrial fibrillation, of course, is increasingly detected by implantable devices. Stroke exists in these patients. It is less common in subclinical atrial fibrillation. The annual risk, for example, in Artesia and NOAA AF2024 was 1.1%, but we are seeing more and more of these patients, of course, because we have so many screening opportunities and so many screening possibilities that our patients are exposed to, and we are receiving an ever-increasing patient population where these devices have detected at least some degree of atrial fibrillation burden, maybe a few minutes, maybe half an hour, maybe hours on end without the patient being symptomatic. And the big question is, of course, what to do with these patients. Should you anticoagulate or prevent them from stroke is maybe a better way of saying, should you prevent these patients from stroke if they have subclinical atrial fibrillation? And the conclusion of this question is very simple: we don't know. It depends on the patient. It depends on the patient. The background is, of course, we do know that there is an increase in stroke risk. First of all, these subclinical atrial arrhythmias tend to evolve to manifest clinical atrial fibrillation. This was shown in the ASSERT trial. And second, not only do they progress to atrial fibrillation, but of course they are also associated with an increased rate of stroke or systemic embolism. Patients with subclinical atrial fibrillation will have a higher probability, although not spectacularly higher, but statistically significantly higher risk of experiencing stroke. And two randomized studies explored whether it makes sense to protect these patients for stroke with anticoagulation, the LAAC trial and the Artesia study, very similar designs, randomizing patients to either DOAC or aspirin. Slight difference in the trials. I'm not going to go into that either, but very similar trials. And as you probably know, there is some confusion about the results in that some people feel that the trials give us a mismatch in their outcome. And I don't believe that's true. I think if you look at the outcomes, you will see what you would expect if you think about these trials, which is that for ischemic stroke, both trials show a reduction or a trend to reduction for ischemic stroke if you put patients on anticoagulation. And the pooled analysis clearly shows this difference to be significant. And on the other hand, as you would also expect, if you give a patient anticoagulation, he or she will be more likely to experience major bleeding. And the result of this is that in the pooled analysis, there is a clear benefit for treating these patients with subclinical atrial fibrillation in terms of stroke prevention at the expense of exposing these patients to bleeding risk. Nothing spectacularly new. The other component to remember if we speak about subclinical atrial fibrillation is also the time to benefit or the time to harm, which is the time until an event happens, and this is not necessarily the same for stroke and bleeding. And again, it's logical once you think about it. So if we have patients with device-detected atrial fibrillation, yes, we know their risk of stroke will be higher if they are on aspirin or nothing versus placebo, but we also, if we put these patients on anticoagulation, we also know that we will expose them to bleeding risk, of course. And the time period for these events is different. Typically, bleeding is a complication or an event that occurs much faster after initiation of therapy than stroke, which typically takes time to develop. So typically, the harm we induce with DOAC treatment occurs before the benefit our patients receive in terms of stroke prevention. And this is where the concept of individualized management comes into play. And then finally, I think some ideas on future messaging might be, so we already covered that the rhythm control strategy can be advised within 12 months of diagnosis. I believe there are many studies already published, such as the Castle-HTX study you see here, and studies in design showing an impact of AF ablation on mortality. I believe the other future messaging in the guidelines will clearly potentially become that LAA closure can improve outcomes. Option has been presented in November of last year. We have a dedicated session on it, so I'm not going to show you any results. And already, as I showed you, LAAC 4 has been initiated, which is randomizing patients to receiving LAA occlusion on top of anticoagulation if they have a high-risk profile, not bleeding indicated, but just for high risk. And option, I said I'm not going to show you the results, and I won't, but I want to show you one slide, and this is the slide of the oral anticoagulation over time. And obviously in the arm randomized to Watchman, very few patients received anticoagulation. But interestingly, in a randomized controlled trial, randomized to oral anticoagulation, patient compliance is 85%. So you can only imagine what patient compliance must be in real life. And this is one of the messages that we published in a recent consensus paper on LAA closure, many of the authors of this paper present here in this room, where we published this particular graph, which tries to convey a framework for thinking about patients with atrial fibrillation, where you start with, after identifying patients at risk of stroke, of course, patients that need stroke prevention, where you assess their bleeding risk and consider if they are a particularly special population likely of bleeding, where you typically will not give anticoagulation, or if you do give anticoagulation, you reassess the effectiveness of this strategy. And typically, for example, failure to adhere or failure to accept is something that is not routinely seen in guidelines, but what we should definitely take into consideration. I will skip this slide, but I want to finish with this last slide, which is also a future message, which is the other end of the spectrum. So we considered patients at high risk for stroke, high risk for bleeding, but there are also patients at particularly low risk for events. So in the spectrum of treatment, you can think about anticoagulation for patients with high AFib burden and low bleeding risk, or you can think about closure for patients with high AFib burden and high bleeding risk, but you can also think about patients that experience very little atrial fibrillation and have a low stroke risk. And because we now have very short-acting anticoagulation, you can think about a trial that randomizes patients, which is exactly what the REACT-AF trial is doing, to either standard anticoagulation or intermittent anticoagulation during their AFib episodes. In conclusion, the stroke avoidance goal remains an essential component of recent guidelines. Dynamic re-evaluation of patients is essential. Catheter ablation is a class 1 indication in paroxysmal and persistent atrial fibrillation patients, but there are clearly, for stroke prevention, unresolved bleeding issues in the management of our patients, for example, in subclinical atrial fibrillation. LAA closure has a role in ineffective or problematic oral anticoagulation, and LAA closure may have a role on top of anticoagulation, which will be studied in the LAAC trial and which will inform future pathways, for example, concomitant strategies on which Jan will present, I believe, or, for example, pill-in-the-pocket anticoagulation, as I just showed you. Thank you very much.
Thank you very much, Tom, for this meaningful presentation and lecture. Do we have a question in the room? Before someone wants to ask a question, maybe we would like your opinion, because when we prepared the session, when we designed the session, and as you know, most of us are not EPs, we talked about indications of left atrial appendage closure. And we have I would say, that will be the topic of Jens Erik's presentation, but guidelines that are not favorable for the procedure. So we discussed when is the best moment to introduce LAAC in AF patients, because usually we go, I would say, when the patient is very old, has a lot of contraindications, is bleeding, which is not the best moment to treat a patient. Should we go up front? Should we go to younger patients? You can go outside the roads. We are in between us.
Well, the question is, are you asking me or are you asking the guidelines, of course?
You.
The guidelines are very clear. Let's see the data. And I think the option trial has answered part of the question for me already. The option trial has clearly opened the window for me to consider and discuss with my patients, although it's more a theoretical discussion because there are reimbursement challenges. But as a concept, it has opened the door for me to discuss with my patient, do you want to be on anticoagulation for the next 30 years or do you want an LAA occluder? And I think it's a perfectly valid discussion to have. Like you said, not necessarily in an old patient. The patients we select for PV isolation are by definition not the profile that you just indicated. Option has opened the door there. What will really, I believe, inform guidelines are the Champion trial and the Amulet RCT, which, yes, thank you, the Catalyst trial, which will truly give us an idea of how sensible this strategy is for all comers, how sensible LAA occlusion is. If you ask my opinion, just have a look at the slide I showed you on adherence. I think LAA closure is a sensible strategy. Having said that, I do not think we have solid data to give it today to a 64-year-old with zero bleeding issues.
Laura.
Thank you very much for the interesting talk. I would like to follow up on solid data and mortality after ablation. So you made a pretty strong statement on the impact of catheter ablation on mortality, and as far as I'm informed, it relies on 97 patients at a single site, open label. And is there any other data that is suggestive of a mortality benefit on top of that single site experience? In an RCT notably, but open label.
I believe you're referring to the Castle HCX trial, so for the end-stage heart failure patients. The strongest data, of course, is the ESC AF2024 data, which is, again, not exclusively ablation patients, but which is, yes, ESC AF2024 shows mortality in 1,200 patients or something like that. So a choice for early rhythm control through whatever means you choose to achieve that, which ended up being a lot of ablation, has been strongly shown to be associated with an improvement in mortality in ESC AF2024. Agreed that the very specific end-stage heart failure patients is still limited data, which is, by the way, for that reason and other reasons, also not a class 1 indication in the guidelines.
Laura?
Yeah, it's just a comment that the option trial just opened a little bit the door, but with the Catalyst and the Champion trials, we will start treating patients that are way more healthier than the patients that we used to treat. And what we show in our patients in the Catalyst trial is that the appendages used to be super difficult to close, because in the new classification, maybe they will be more towards 3 or more than to the EC appendages. So I don't know, maybe this classification could be an option just to, you have the patient, you do the pre-planning, and if it's a very EC appendage, maybe you go with the ablation, or in the future you can decide where your patient. But I think will be a problem because I think that the trials will be positive, and this will open the door to treat a lot of patients and a healthy patients, and it's a preventive intervention, and the complication may raise if the centers that start closing the appendages are not centers with a lot of experience. So I think it will be something that the numbers will high, but then maybe we will have a problem with the therapy because people will start thinking that maybe it's a problematic therapy. I don't know your opinion.
Well, it's an excellent point on preventive therapy, and of course the success of the strategy will be driven by the safety by which you can implement it. But I would argue, yes, I agree with what you're saying. I would argue DOAC is also a preventive strategy, which is not free from concerns. And it's a simple question. If Champion turns out to be positive and you ask yourself the question, if the Champion data solidly shows LAA occlusion is a good alternative to anticoagulation, and you get the message you need stroke prevention, are you going to take anticoagulation for the rest of your life or choose a device? I think I know. But yes, of course, the therapy needs to be safe. I do believe that the increases we've seen in LAA occlusion over the past decade have driven the feasibility of these trials. I don't think we would do these trials with first-generation devices, and I believe the devices that are upcoming, it is logical to assume that the safety profile will increase. The safety profile of DOACs will not increase. It is what it is. It's going to stay that way until we have factor 11 inhibitors, and the first trial was not great, was actually not promising. So that safety profile is what it is. The safety profile of appendage occlusion can only improve.
Yes, and maybe we can add that the safety profile of drugs is depending on patient's profile. And the safety profiles of the procedure is mainly depending on the experience of the center and the operators. So, which makes some additional discussion very interesting for the future.
But it is a great point, actually, now I think about it. If you, of course, open the indication and expand the procedure to a lot of centers, I think you need good guidance on how to do it safely. Absolutely.
Absolutely, and that's a critical part of the discussion because, as you know, and this is in the survey that Ignacio mentioned, the median number of procedures in European centers, LAAC procedure per year, is 25, which is dramatically low. I'm sure Aaron can imagine what happened in the US now, and the median number is 25. So we are doing at median 2 procedures per month, which is not experience, which is not skills. Okay, Sergio.
A few seconds for the last question. Tom, you mentioned the fact that in patients with subclinical AF, the risk of a stroke is lower. Why?
Lower than the patients with clinical AFib. So they have an increased risk of stroke compared to patients in sinus rhythm, but their increase in stroke risk is not as pronounced. So the increase in stroke risk from baseline for clinical atrial fibrillation is 4.5% per year on average, if you take all CHA2DS2-VASc combined. In subclinical AFib, it's only a little bit above sinus rhythm, but it's increased versus sinus rhythm, just not as much in the clinically overt. Why? Because apparently clinically overt patients have a higher AFib burden, have perhaps other comorbidities that lead to the discovery of their AFib. The patient profile is different. But let's be very clear about the fact that we do not really have good risk prediction tools for stroke. We lack good capabilities to identify patients with an individual high risk of stroke. The CHA2DS2-VASc score is the best tool we have, but it's very poor. It's a very crude instrument.
Joe, last short question.
It was just to complete. The answer is that subclinical AFib is a kind of recent concept that comes from the devices which make loop registrations and everything. And the first reaction of physicians was to anticoagulate somebody because we saw some AFib, and then we realized we made dangerous prescriptions, and the new recommendations take this in care and make a lower recommendation to anticoagulate these patients, because effectively when you find this, you can find sometimes a few minutes in a pacemaker or defibrillator or a loop recorder. So it's a really particular medical concept which was not considered years before.
I agree. I think it's time to move on, and it's my pleasure to introduce Jan Kovac, who will give us the real answer to all of these questions, when to introduce LAA closure and its role in comprehensive AFib management.
Colleagues, my teachers and company, thank you very much. Yeah. So it's okay. So when to introduce, so I'm an interventional cardiologist, I'm not electrophysiologist, and in my disclosure, maybe the last one is slightly relevant because I'm also ESC, as we know, and Jens will talk later. Guidelines were not that friendly to appendage specifically. Get on it because Stroke Council, which is part of ESC, has got its own conference, and one advantage of those councils, we are part of guidelines writing. You can nominate your own person, so I encourage all of you European people join that council because it's all clinicians. So I'll talk from point of people who are referring to us for our expert procedure. So we know that AF is very common, 34 million of people. There is high risk, obviously. The clotting and stroke is one of the main concerns. That's why we're here. We manage rhythm, but from my perspective, even more importantly, we manage those clots. So with evidence, it's as it stands. So currently, obviously, we have those ongoing primary trials, but what's clinically accepted is patient essentially appendage having, if there's a contraindication to anticoagulation for one reason or another, or unable to take, unwilling, etc. The rest of those things are investigated still, as we heard. There is some promising trial coming up. These are guidelines. Again, Jens will be talking about it. There's also involved guidelines, which are a bit older, but they are very similar than if a patient got for anything else with a valve, so you look into it very much same way. And again, I will not allude too much to somewhat disappointing, a low grade, but grade comes with evidence. We need randomized study, and then go up, and essentially that's what you need to be in class 1, which we have for surgery. Again, Tom already mentioned. So hope is there. How would it start? Actually, was if there was no LAAC, it would be no brainer because original studies and concept, which is about 20 years old, show that it is better, or get better over the time to warfarin, and as time goes by, get more MS superior. So it would be nice even with those early, relatively primitive devices. And it was there compound with a similar situation, other studies, analyses with Prevail, and more recently Prague study, which was interesting study to me. I'm originally from Czech. There was relatively little experience of operators and still achieve quite good results in terms of non-inferiority. Same time, if we look into real life, seems to be actually patients are potentially benefiting more if you are in a similar indication than in trials from this recent analysis. So we do procedure well, and we do it quite safely, which is absolutely important part of it. And again, from Jens, Erik, evolution, again, all postulated and observed risk of all events which are looking into ischemic stroke, non-procedural bleeding, combined point, were better observed than expected, and it across whichever strategy of antiplatelet, anticoagulation, nothing chosen afterwards. Still, indication various registries primarily is for bleeding, major bleeding, undisputed. Obviously, apart from those Protect Prevals, we don't have any direct randomization, but that's what we feel as a multidisciplinary team. It's indication, and there are some other indication. This is just from another aspect. Again, bleeders and people who are prone to bleeding, they are main indication across the spectrum hospitals implanting LAA. And again, we are here cardiologists, mostly interventions, electrophysiologists, but we need to rely on all those people, because many patients, they don't see us in fibrillation, especially I practice in UK. Most is managed by GPs. They are prescribing medication. Some of them get to ablation, etc. So they actually see patients more with those complications and need to think about those procedures and considering alternative option. So we need to get out of the community, get more referrals. There's actually, probably you've seen this paper of this week, Jack, did actually artificial intelligence and help us in our decision process. They took all US 700,000 patients, analyzing all possible factors to AI, inclusive from known like dementia, MI, but falls, presence of nurses in the unit. So there are some logical aspects if the AI looks at it. If you don't have a nurse in nursing home, patient falls more often, his anticoagulation will fall down. So we might see some changes again with this technology coming out, even of things like potential atrial appendage closure. This was only, I saw it yesterday when I was finalizing my talk. So it's fascinating how much more decision we can put into our multidisciplinary teams. There are various other indications. Essentially, all show they're slightly more prone to bleeding. They are here, the angiopathy, macular degeneration, various hematology diseases. And obviously, what's growing now, there are procedures on elderly who have also fibrillation coming for TAVI, mitral procedures or other procedures. We also know that even if they don't have a clinical big bleed, if they are usually older age group, even though fibrillation obviously starts early on, they got quite a high presence of either atherosclerosis or cerebral amyloid angiopathy. So this is very common as we all age, especially in the Western world. And we know that hemorrhage risk grows with, depends how your angiopathy is visible, and it's actually equivalent to it from deep mixed lobar to disseminated. So it depends where you go your corticosterosis you can derive. Even those patients who didn't have any definite clinical bleeding event, there is bleeding risk. So again, those people are all risk taking anticoagulation, so they can potentially be considered for preventive treatment even before any primary trials. And we know that if there are microbleeds observed in patient fibrillation, this got impact on their mortality, on intracranial bleeding, regardless whether they are on single or double or multiple therapy or anticoagulation or antiplatelets. Kidney disease, of course, there's high prevalence of atrial fibrillation. There's a high risk of bleeding. They go generally high mortality, high risk of stroke, and NOACs are contraindicated, and warfarin is often prescribed, is unclear, and seems to be not doing that well, even if it's prescribed in this situation. It's being addressed in upcoming kidney trial. You're probably aware of kidney trial coming from Germany, which hopefully will shed some more light. So be another indication. Gastrointestinal bleeding also, that in DOACs může být increased thrombotic, which you need for case of bleed. So it can be counterproductive having even DOACs, not only anticoagulation in the coumarins. And those patients are not planned, they come with bleeding, they are not really analyzed from that aspect atrial fibrillation. So again, for us, the education going to community, those gastroenterologists part of the multidisciplinary meeting, and just think about appendage closure as an option here is if that bleed is recurrent and source is unidentified. We want to combine them because TAVI, done in my place, we almost TAVI procedures, thousands in a year, and they fibrillate in big numbers. As we know, fibrillation is common because they are older. This is all from randomized trials. There are a lot of cardiovascular factors, again, basing on their comorbidities and older age. And we know that if they bleed after TAVI, they got the risk of all bad events from mortality to stroke. So we will watch our trial, which is an interesting trial, which is comparing only TAVI, medical therapy, or TAVI to appendage closure. And it was comparatively, and obviously we got early results, which are non-inferior 2 years as a combined, but again, one would hope it will be like PROTECT over the time, that bleeding risk is not there, because you don't need an anticoagulation. So it's something promising start, and it's for individual endpoint as well, stroke, major bleeding. So concomitant is non-inferior, seems to be safe. And probably there's one possibility. Patient is on the table, is 80 years old, he spent all money on him, so why not to do such a procedure? So it's certainly potential appealing concept. Same is for mitral, growing very rapidly in some countries. Mitral clip, and similar again, they got very commonly high bleeding risk, and they got commonly frequent atrial fibrillation. We don't have any sorts of randomized data here, but it seems to be procedural success is very similar from registries if you do single procedure, if you do both procedures. And again, in observation, which is not randomized trial, there seems to be tendency reduced bleeding after procedure while being non-inferior in all other aspects. I'm not electrophysiologist anymore. The isolation itself is associated with decreased atrial fibrillation, persistent, but can have more thrombogenic effect. So it's mechanism that ablation with closure is beneficial in those patients when you perform ablation also of appendage. So those patients would make sense. They have both. They got more complete ablation, and you add appendage on the top of it. Obviously, next big thing, next year, this meeting will be packed. We have a huge place for planning because I believe we should hear something from those primary medication. Because to me, at the end, appendage should be indication for treatment of atrial fibrillation, and then team decides in what situation is indicated for. Also, because patients just don't take tablets. These are originally data when NOACs came along, and still adherence to therapies. Barely half patients, and it's only first couple of years. Taking lifetime management, to me, would be no-brainer. As Tom Potter says, you go to one procedure, or you just take tablet with possible side effect all your life. So 2 main studies coming up, Champion, Catalyst for primary. We already hear option. I will hear more about option, and there are some other studies. So I was one of the recruiters for Watchman. So again, you all know Watchman is comparing the Novo strategy with strategy of NOAC, and obviously after Watchman you can only go for aspirin. So hopefully aspirin will not spoil the show. I'm also confident if operators are good and skilled that it's almost foregone conclusion. So it's very important, we call it in UK, in NHS, multidisciplinary team, multiple meeting. So because patients are not catered by implanters, indication comes from outside cardiology, and we need to balance all those together. And also there's a regulatory requirement, different commissioning. I actually, agreement I put to ChatGPT and is in agreement with me actually before preparing lecture. So even artificial intelligence agreed with me on those strategies in appendage closure. And I come back to Tom Potter. I was also privileged part with few of you in this cookbook for non-implanters, how to choose this multidisciplinary approach because patient coming from outside. It was published in Europace, it's available, it's good to disseminate for your referrers, which again to me are not just cardiology specialists, but also community doctors. We got similar thing in UK, which is mandated by so-called NICE guidelines, so you need a team to decide, so actually implanter is not the one who is deciding who gets appendage. And I will finish here with some future developments. Thank you very much.
Thank you, Jan. We can certainly also discuss Adele. Go ahead.
I have a question to you, Tom, because we are talking about lifetime management. So if you just make a scenario, okay? Imagine you have a 60-year-old guy that you ablate, okay? And he has hypertension, he has diabetes, so the chest VASC is 3, okay? And then you have done a successful ablation, but you know that there is a risk of recurrence, you know. And then the patient, based on the chest VASC, you will put him on NOAC instead of closing the appendage. And so this guy has probably a long life expectancy, so you accept a yearly rate of 3% of major bleeding, so over his lifetime it's going to be a lot. And also the adherence, you know that after a few years this patient will stop his treatment. So just from a hypothesis scenario, you know, like wouldn't it better actually to close the appendage and then the patient get rid of this drug and this danger that will be over his head for a very long time?
Well, yes, and the patient you illustrate is a potential candidate for this discussion based on option, but the very specific scenario of stroke risk after PV isolation is another can of worms. We don't know. We simply do not know. The surgeons make it very easy. They do thoracoscopic ablation and they say everybody's cured and they go off anticoagulation. If they do open surgery, they close the appendage, of course. There is a specific study, the OCEAN trial, looking at successful AFib ablation, randomizing patients to stopping or continuing anticoagulation. The results are not out. We do not know yet. There's a lot of data indicating that stroke risk is significantly reduced post successful atrial fibrillation ablation. So honestly, it's a can of worms. But all else being equal, if I have to choose whether I got an ablation or not, do I want an occluder or lifelong anticoagulation? It's a discussion worth having. And of course, if you get an ablation, you take away some of the risk. If we talk again about preventive strategies, you're there anyway. You're doing the procedure. You already did the transeptal. You already did the vascular access. So it makes sense to believe that you can capitalize a little bit on combining the procedures. Having said that, there's also some arguments to do it sequential, not to do it together. And it's one of the questions I had for Jan also. I know about the arguments in PV isolation. In TAVR, I'm less clear on whether it makes sense to do it in one procedure, which then becomes a fairly complicated procedure, or to do it sequential.
Well, I guess TAVI is probably quicker these days, so it's probably less problematic in terms of scheduling than ablation, even the fastest. And so economically, apart from cost of device, patient only comes once, and they are elderly for his logistics. So there is something to do and combine, and obviously study was non-inferior, and if patients are defibrillate, there was, so I think there is something in it. For because like in UK having a lot of ablation and appendage elsewhere, again, how many, because we got not many beds, you want to have a patient, many throughput patients, so economy to different countries, different healthcare system can be different. Some places you are paid more if you do it sequentially. Some places you are paid rapid turnover, which would work for UK. So it's, I think, be individualized. But I got one more to you. When we did champion study, just from position of patients, and I know it from PFO as well. If you tell patients, you need to take this pill and bleeds. Some patients, I don't want to take pills. But then also smaller group patients, I'm scared of any needles and patients. So at the end, it's patient decides as well. And if you got this, we just give him options, so he might play more role than if it's severe aortic stenosis, not much choice. But here there'll be always patient choice.
Thank you. Oh, Joël.
If we imagine to close the LLA younger patients at low risk, do we have any information about the long-term durability of the prosthesis in the LAA? Are we reassured about that, or?
Well, I don't hear bad press. None of us here, but of course we don't. But then comes back to, we got all these plug devices, got a beautiful anatomical session, but maybe in the future, if really primary, you stitch it together, so you forget about your 3D measurement. So there's so many unknowns. So we are the starting point. If there is evidence, it will grow itself. Again, analogy with TAVI was one primitive. We are happy it stays in, patient is alive, leak, and where we are, whatever, 10 years later, it'll be similar.
We have looked at durability of the LAA occluder devices after 5 years, firstly on the amulet, which is now published, and there's no structural damage to the frame or anything that indicate that there is a problem on long term, and we are now doing similar study with the Flex device, and our preliminary results says the same. There's no fractures or disintegration of the frame, so it seems to be very stable. And I think at least if you have a good sealing, you have a lot of scar tissue that is stabilizing everything, and it's probably totally covered and innocent in the long run, I think. But it's a good point. We don't have follow-up after 10, 15 years, of course, systematically, but
I mean, one would expect it's covered, endothelialized, thick, invisible. But I would ask back Jens, because he knows, if those primary studies work, do you think you'll still be plugging it, or there'll be some fundamental different technique leaving nothing behind? Do you think there'll be fundamental change in design, what closes appendage, if we prove clinical point it works in primary indication?
Yeah, I definitely believe that we are just in an early phase of the development of LAA occluders. They will be even more effective in getting complete seal and also in safety, and reduce the risk of erosions, tamponade. So there will be a continued technological development, and maybe the future will be some kind of filling with a substance like in construction of buildings, and you just fill the appendage out with a substance. So yeah, there will be a development surely.
Because another, it's what Tom, I think Chinese technology, you got actually ablatory catheter on appendage is hooked on it. So both things are one device. So ablate and plug it in. So that's, I think we are at the beginning.
Yeah, sure. That's just the beginning of the story. Thank you, Jan. My pleasure to ask Erik to give a critical view on ESC AF guidelines.
Yeah, thank you. So last year we had the new ESC guidelines, 2024 guidelines, and I think we have been looking for an upgrade in this recommendation for many years, and it stayed the same 2B, and I think it came as a quite big surprise for many of us that actually the level of evidence was downgraded from B to C. So in the top here you have the 2020 recommendation for percutaneous LAA closure. It was 2B. Level of evidence B, now it stayed 2B, but evidence level was downgraded to C. On the other hand, there was a development and a movement regarding surgical occlusion, because this is now a class 1 level of evidence B recommendation. It's not a standalone surgical closure, but it is seen as an adjunct to all anticoagulation, and this is of course based on the layer 3 surgical trial that proved that on top of all anticoagulation you could get more stroke prevention. But it was quite disappointing for us to see that the level of evidence was now C, especially if you look at the requirements for getting a level of evidence B. Just you have to fulfill that data should be derived from a single randomized clinical trial or large non-randomized studies. Now we are down to no randomized clinical trials and only consensus of experts and small studies, retrospective studies and registries. So it was, I think, a little bit provocative, because this is a demonstration of what was available at that time. The 2024 recommendation came out, and we actually have 3 randomized clinical trials, PROTECT, PREVAIL, and PRAC-17, and this is the summary of those trials. And as you can see, and you all know, that those data show that we can get the same stroke prevention with LAAO as we can with oral anticoagulation treatment, and we get a benefit in terms of reduction in hemorrhagic stroke and in non-procedural major bleeding. And we also have a signal regarding all-cause mortality and cardiovascular mortality in favor of left atrial appendage closure. So it was quite disappointing to see. And also at the same time, you know that for every year the number of publications related to LAA occlusion grows. We have now at least 2,400 publications on LAAC, and Ignacio showed us also just in the last year we had around 500 publications. It was not known to the committee, the option trial results. They came out later in November 2024, but this will also, I think, hopefully change the game. But already with the data that was out there, it was a big surprise for me and for many others to see this 2BC recommendation. And it was not either aligned with the US recommendations, because in ACC, AAH, etc., all the societies in the US, there was consensus that at least in patients having a contraindication for long-term oral anticoagulation, it could be a 2A recommendation with a level of evidence B. So they divided it up, and of course, talking about patients that just had a higher risk of bleeding, that could also be a recommendation, but with a weaker level of evidence. But surely the European and the US guidelines is not aligned. And I mean, we all had the same data to look on, so this is a bit confusing also for clinical guidance that we have this discrepancy out there. Looking a little bit closer on the European recommendations for percutaneous LAAO, I think one of the very important things for this procedure is what is the safety for this procedure. And what you can find of wording in this 2024 document is that voluntary registries enrolling patients considered ineligible for OAC have reported low periprocedural risk. But what really stands out with specific numbers is a publication going back to 2017 with the first Watchman Flex generation device, telling that adverse event rate was up to 9.5% in 5 to 15 in low volume centers and 5.6% in high volume centers. And this is really totally outdated information. At the same time, we have data from nearly 100,000 patients receiving a device that is used now, a currently used device, and you can see that the procedural risk with this device is extremely low. You have pericardial effusion down to 0.4% and device embolization down to 0.04%. And I don't like that you take an article based 8 years old with a first generation device and highlight the procedural risk. And that is, for me, very biased information. And we also have procedural risk information from the option trial, ablation plus LAAC, 2.8% in total, only 0.6% device-related complication, etc. Also very low effusion tamponade rate in the option trial. So this is not very good data, I think, to report in this guideline. Also, if you read the guidelines about the post-procedural antithrombotic therapy, because what we sometimes meet is, why do you do left atrial appendage closure? Because anyway, you put your patient back on oral anticoagulation, antithrombotic therapy, and they get a lot of antithrombotic medications. So why do you do this procedure? And here in the guidelines, it's referred to that the regimen after LAAC, it's 45 days of VKA plus aspirin, 6 months of DAPT, and etc. This is historical information. It was Protect AF protocol. Current recommendation for Watchman Flex is DAPT or DOAC for 3 months and then aspirin for 12 months. And for the Amulet device, it is aspirin for at least 6 months, and clopidogrel, you can add that according to institutional standards. So why this misinformation in current guidelines about the regimen for antithrombotic therapy? I cannot understand why that is going on. One thing and one argument regarding randomized clinical trials for this committee has been that those trials were done with warfarin, and then they refer to DOAC versus aspirin, because in the average trial it was, according to the guidelines, shown that apixaban and aspirin had the same risk for bleeding. So they are telling us, if you are just looking on VKA trials versus LAAC, that's totally irrelevant, because now we have the DOACs and they have similar risk to aspirin. But the average trial was a trial with highly selected patients. They had no history of bleeding. They had normal hemoglobin. It was highly selected patients, and even the hazard ratio was actually a little bit unfavorable for apixaban. And still, it's a little bit strange, because warfarin and VKA is still a class 1 recommendation in the guidelines. So I cannot believe this argument. And also looking at other trials like the Artesia trial, which Tom has shown us already, there's a difference between aspirin and DOAC. So there's much higher risk of major bleeding having apixaban than having aspirin. Also remember that DOACs were not actually significantly better for stroke prevention than warfarin was. All the DOAC trials were designed as non-inferior trials, and they were actually non-inferior to warfarin regarding stroke prevention. So the only thing that came out from those trials was that DOACs were better in preventing, or there was lower risk for intercerebral bleeding with those drugs. That's the only benefit that really could be derived in terms of bleeding. And looking at, for instance, gastrointestinal bleeding, it was more risky with DOACs compared to VKA. So how can we just ignore large trials that have been conducted with warfarin against left atrial appendage closure? I cannot believe it. One thing that is also in the guidelines now, which I have difficulties in accepting, is that the message now is almost forget about bleeding risk scores. So if you look at the class 3 recommendation here, use of bleeding risk scores to decide on starting or withdrawing oral anticoagulation, it is not recommended in patients with AF to avoid underuse of anticoagulation. So you only have to look for if the patient has a modifiable bleeding risk factor. Then you have to take care of that. But if you have a patient with a low hemoglobin and there was no bleeding source found during several diagnostic follow-ups, we don't have to take care of that. Just start anticoagulation, because we should prefer stroke prevention. It's totally crazy. I mean, why can we accept this? We need, I think, in every patient really to try to estimate what will be the risk for the patients in terms of bleeding. Because we know that bleeding is an essential adverse event with DOAC therapy. This is the Garfield AF cohort of patients, and this is a broad AF population, and we see bleeding on DOACs more than 4% per year. And if you combine it with aspirin, it's more than 6% per year. And most importantly, we know that having bleeds on DOAC is actually a factor that increases the mortality. So you cannot ignore bleeding, and I think we need some kind of very thorough estimation of bleeding risk in all our AF patients before we just start on DOAC therapy. In the ESC guidelines, there's not a single word about adherence to therapy, and Jan showed us that adherence to DOAC therapy is down to 50%. But I can tell you it's even worse if you look, for instance, on patients that have AF ablation. It's even worse. And we also know about several other studies looking at adherence, that 1/3 of our AF patients that we start on DOAC will be out of the therapy after 1 year, and the rest that are left, not all of them are really taking the drugs in a relevant way. Another issue out there and a challenge for AF patients, when they come into the stroke units now having AF and a stroke, almost 50% will be in DOAC therapy. So they are in some way DOAC failures. And how can we, the guidelines really don't offer a lot of guidance for these patients here. So you can do a thorough diagnostic workup, you can talk about adherence and things like that, but what about those that are really taking their drugs and are having stroke on all anticoagulation? There's not much help in the guidelines. And we have now several studies. This is the study from Lucas's group demonstrating it's a propensity score match study. It's not a randomized trial, but there is really a huge difference in this population having stroke on oral anticoagulation, getting LAAC. They have a much lower risk than apparently when you just leave them without anything or continue their oral anticoagulate treatment. They have a very, very high risk. So I think those guidelines, they don't seem to be particularly friendly to LAAC. I don't believe that 2B level of evidence C status is a fair reflection of the available evidence. I can see that European AF guidelines, they are definitely not aligned, despite we have the same pool of data. We have no guidance for very essential issues in AF managing patients. We have no guidance on what to do when the patients will not adhere to therapy, and not really a good guidance if they get a stroke on DOAC or oral anticoagulation. I think they are also already outdated because we don't have the option trial results into the guidelines, and do we really have to wait 4 more years on relevant guidelines? So what can we do currently? Thank you.
Thank you, Jens-Erik, for this great lecture. We can talk, I think, probably 2 hours for that, yes. Which is not the purpose. But there's one point that is really interesting, in my opinion, is that the American guidelines, as you mentioned, is going up, while European guidelines is going down. And the main reason why that we hear from colleagues is that they are anticipating the results of Champion and Catalyst. And in some way, I think what we heard from Tom, and he's in the list of the of your friends, Jens-Erik, is that in Europe we are waiting for the results. We are not anticipating. That's the main point I can imagine. And well, this is my point. How do you what this says from, I would say, European system or European medicine or European, I don't know, about what we want to do for the patients?
Of course, we will have more support for the therapy waiting for the Champion and Catalyst trials, but it will not address patients that have contraindications and that are bleeders. It will address patients that actually tolerate oral anticoagulation. So And I think most of us here believe that where the benefit is highest is really those that cannot take an anticoagulation drug without getting bleeding issues. So in some way, we have to create some recommendations for this group of patients. It's as it is now with those guidelines, this group is almost left alone. I mean, I think that also we are always mentioning Champion and Catalyst, but Closure AF will also be maybe the next trial that can help us to, hopefully it will show that we really can do benefit for those patients.
Or probably comment. I can also understand your anger about the guidelines, but when we are honest, in the guidelines they speak about contraindicated patients, and all the trials that are mentioned there are for patients that were not contraindicated. The only trial that I know, maybe I forget, is ESAP. ESAP were 150 patients, contraindicated patients, not randomized. And probably they are right with the evidence level of C, but they forget that we have 3 randomized trials, or probably more, with patients that were not contraindicated. The 2B B should be for patients that were not contraindicated. The 2B C should be for patients that were contraindicated, in my mind. What do you think?
I get your point, but it's not totally correctly, because the PRAC-17 trial is actually patients that have a very high bleeding risk and that are unsuitable for long-term anticoagulation. So we do have also randomized data in this population. But what is the difference between having a very high, if you look at the bleeding history in the PRAC-17, I cannot remember the percentage totally now, but it's probably around 85% of patients that had a prior major bleed and a very high bleeding risk. So where do you put your definition of having a contraindication?
So if you say patient is contraindicated, then you cannot randomize the patient to apixaban. And they were randomized to apixaban or device. So it's a course of definition, clear.
Yeah.
But when you say they are contraindicated, then you cannot put it in the PRAC-17 trial.
I think 2 things. For current patient, we just, and that's that Cook was about, get to referrers, because many patients, they bleed silently in community. That's what we are trying to go to non-implanters, non-electrophysiologists. Therefore, current, just to growth experience. For study, having spent 6 years now in those ESC degree, just be part of it, be part of next guidelines. Luckily, fibrillation is such a big priority, probably get again in 3 years' time, because some other guidelines, there's competition or goes to guidelines. AF's got chance being there next time again. So be prepared, come 2027, and half of people from here be co-writing guidelines. So 2 things. Short term, get non-implanting doctors sending more patients with what are current accepted. And second one, being part of guidelines when they come next time.
Yeah.
It's not that far away. Time flies.
I think we have, but we come back to discuss the option trial. But now we have randomized data for a totally new subpopulation of AF patients, and it's not considered at all in the guidelines. So you could also argue that we need some kind of addendum to the current guidelines, because they are really a limitation for broadening this therapy out, I think.
I want to comment on that. First of all, I agree with the discussion on contraindicated. I think it's a historical mistake. It should never have happened. Nobody will die from a single dose of DOAC. Nobody has an absolute contraindication to anticoagulation, and all of us will die from indefinite exposure to DOACs. It's a historical mistake, and it's much better, I think, to speak of the way the US people phrase it now, to say people who have an appropriate rationale to seek alternatives to anticoagulation, I think is a much better way to think about this. But in general, about the guidelines, I want to comment, to be clear, it's not the Tom and Jens Erik guidelines. I am happy to submit the proposal, but I do stand by the message of what was published. And for me, what the learnings I've had, and I share your confusion is not the right word, you're wondering. I don't share your anger. For me, the observation is what is perception of LAA closure in the community. And as you very well know, some people absolutely feel LAA closure is a class 3 indication. You are a criminal for performing the procedure. John Mandrola is probably the best known example of this, but this sentiment exists in the community. And the ESC guidelines are based on data that we have, which is, for DOACs, if we are honest, relatively poor. I can live with the class C level of recommendation. The guidelines do not say patients that have stroke on anticoagulation, don't give them an occluder. No, you refer to experts' consensus and expert opinion. What the guidelines do not say for the broad community of GPs is refer everybody with stroke on anticoagulation for appendage closure. That's true. But this data, to be completely honest, also does not exist. For me, the interesting observation is how is LAA closure perceived in the community? Not always favorable. And the answer to your last question, what can we do? I think increase awareness, which is what we are doing. By putting out these position papers, by putting out consensus papers, increase awareness. The data will come from the randomized trials. Until that, we increase awareness. And I don't see what is in the guidelines today as an attack on LAA closure. Yes, it's not openly supportive, but this is the way the perception is in the wide community.
Can I say one thing?
Yes.
Maybe because you ended with what can we do, it's maybe also because a lot of the studies are sponsored and maybe we should have our own studies that are free from this bias.
Well, to be honest, I don't think, I see where you're going, but the major criticism I'm aware of is more lack of size, of volume. For example, Prague 17 is heavily criticized for being a single center study, for being low patient numbers. I don't think, for example, Champion will be criticized for being an industry-sponsored study. I think it's a massive undertaking. I don't think Option will be criticized for that. My opinion.
Well, yeah, when I fully agree with Jens Erik that the guidelines are, whatever you say, it's unfair, because the rise of the evidence in the US guidelines is because in the US, due to the explosion of the procedure, they see, the US people that have written the guidelines, they see that it's safe and effective. And so they see thousands of patients close with low rate of stroke, and so they base their raising the evidence in more contemporary data. So I fully agree with what Jens Erik said, that it's at least you can at least acknowledge that it's becoming a safe procedure with a low rate of stroke, and that is unfair that they downgrade in the guidelines, because it works very well actually.
Berti?
I would like to add an aspect that I only became aware of in some discussions with the US colleagues. I mean, we're talking about data and I think that the guidelines will be fine once we see the two big randomized data versus NOACs be fine. And I think that's missing, and I always understand the guidelines that they are pushing us into that direction, and we need to do them good. But I think there's a big difference between the US and Europe that we are fighting in the background, in that, if I understand correctly, the US might contradict me, if as a US patient you have drugs, you most of the time pay for you themselves. You have to go to the pharmacy, and the NOACs are expensive. So if you get a procedure, then you're done with it. In Europe, it's the other way around, at least in Germany. The NOACs, you go to the pharmacy, you get them for free. Even if you put them in the trash, nobody worries. And I think this is something that we should not underestimate, that we are fighting somehow this perception of a procedure versus drugs in the back, where we can't do anything about it. Huh?
I think you're absolutely right, and like Philippe said, I think we can discuss this all day. Happy to do it later, but first I would like to end the discussion right now. Thanks, Jens Erik, and invite Philippe to the stage to give his view on consensus and what perhaps future perspectives might be.
Thank you, Tom, and thank you all for the great discussion. As you know, we will from this discussion build the consensus for next year. So it's not the final one that I propose, it's just proposal, and we will think about. I think the discussion is really nice about lifetime management. First, we discussed that a few months ago. It was because we thought, so in parallel with TAVI, because now more and more we are treating TAVI patients earlier, younger patients, asymptomatic patients. Of course, there's no need for this procedure, but then we thought, okay, what is the best moment for LAAC to be proposed to the patient? And this is something that I've been very, very happy to see in Tom's presentation. From the key new aspects of the guidelines is that it is patient-centered management. And I think it's something that is really important for us, because what we do is for the patient. But then, if it is patient-centered, it should be patient-oriented. Another point that I think is very important is the periodic reassessment of the stroke risk, because when you are 45 or 50, you are not yet old, of course, by definition. Not yet you have hypertension or vascular disease or any of these things, and you start anticoagulants and you keep them for years, which may be not the best option for you. So I think we have to think about periodical or repeated assessment of the stroke risk, which is something that is really, really important for the procedure. Another very important aspect from Tom's presentation is about silent. You say subclinical, I would say silent, like very short. We said it's a new concept, that sometimes, maybe some of us, we have a few seconds of AF and we don't know, and of course we don't take anything. And what we understood from Tom's presentation is that is not something without sound, or I would say subclinical, but not without risk. And this is a new, I would say, a new goal for the procedure, a new goal for stroke prevention. So we have all these patients, and we know that, patients with a high bleeding risk, patients with drug failures, and concomitant procedures. So we are, I would say, little by little, we are increasing the population that is targeted by stroke prevention, treatment, and procedures. But still, from Jan's presentation, I take this one, that we still are managing patients at very high bleeding risk, like contraindicated to oral anticoagulants. You see here, it's about contraindication. It's the red case. And all the rest is, okay, we have to discuss, but LAAC is okay, which is what it is today. And this does not, and Jens-Erik mentioned that, take into account non-adherence and ORC treatment failure. And as Tom said, I really prefer to consider what is in protocols, in trials today in the US, which is your patient recommended for oral anticoagulant, but has an appropriate rationale to seek a non-pharmacological alternative, which is very, very interesting. It's not, you cannot take a drug, you have to have a device. It's not this much. It's, okay, you are at risk of having a stroke. You can take drugs if you want. If you have a, rationale that you want to have something else, this is something that is very interesting in these new definitions. Because we know that RCTs have paved the way. We know that LAAC eliminates the primary source of thromboemboli, reduce stroke risk. We know that there are a lot of clinical scenarios that are not taken into consideration by the guidelines. All of this, of course, but there's something else, that is patient's preference. And patient's preference for me is something that is much more important than, some niche like I have, I don't know, someone on my eye or something that is a good indication for the procedure. patient's preference, what it is. It is about, and this has been proposed by guidelines to be implemented in all guidelines. It is about patient information and accept that patients' willing, patients' preference is part of the strategy. And you can see that even the FDA is proposing, we are valuing the experience of perspectives of patients. We believe that patients should bring their own experience in helping the agency to evaluate So everyone says, okay, patient's preference is important, but at the end it's not done. So I think future trials may implement patient's preference in design of patient selection. We should know that patient agrees or not for this. Of course, they agree for the randomization. They would not be randomized. But we have a lot of patients, and I'm sure you have, that are completely disappointed when they are randomized to the drug arm. I have some of these patients. You said, okay, you may have the new procedure, which is really, very, or you can have the drugs. And at the end said, okay, for you it's drugs. This is what I call patient's preference. They would say, okay, but I wanted the device. This is why I accepted to participate. Yes. So guidelines are very unclear from that point of view. And they become, for some of us, misunderstood. So I hear the arguments of Tom. There are some, people, you said Mandrola, we have Roof, we have other ones that say, okay, this procedure is just for cowboys. It's not something for patients. But, okay, what is the result? Is that very few physicians refer patients for LAAC. Just this example in France, my country, 10 years ago, the healthcare system wanted to rate the number of patients that would be treated with the procedure. They said there are 30,000 patients in France per year hospitalized for a bleeding, a severe bleeding requiring anticoagulants. And 10 years later, only 2,000 procedures. So we don't treat these patients. Even the procedure is restricted to high bleeders, have high risk for bleeding patients. We don't treat all these patients. And we are requested by courses, as I said, and by all these educational things, to explain for which patient the procedure is designed for, meaning that a lot of physicians, even specialists, do not really know for which patient this procedure is about. So, and one more argument is about, the difficulty to recruit patients in trials where patients were eligible for drugs. And we had this difficulty in Europe. So I think the best is to have individualized medicine. Of course, we have to take the results of randomized trial, but rather than restrictive indications and rather than economic, I would say, purposes or guidelines, because in some countries you don't only rely on the guidelines, but also on economic restrictions. I think the best is to try to define together the best indications. And Jans showed these slides, and what I see here is informed patients. Informed patients is at the center of the figure, and I think that our patients need a clear, honest, and balanced information, and they know, and they have to know about the safety and efficacy of the procedure and the drugs to have a wise and oriented information. So what about the guidelines? Jens-Erik said a lot, and I think we, as I would say, supporters of this procedure, we are really, really thinking the same. Okay, the guidelines showed that. Thanks to LAAC, we have now class 1 recommendation for surgery. LAAC, you know that it was LAA exclusion plus drugs versus drugs, and there was some difference. There was some positive difference in terms of the closure. But there are missing areas. We have patients not requiring surgery. We have non-adherent patients. We said 25–30%, I'm sure it's much more. This is after 1 year, but after 2–3 years, we know from Garfield and other registries it's much more than 50% sometimes. We have failures, strokes despite anticoagulants. We have now the new data of option, and we know that the skills of the team, more than the operator, but the skills of the team is something that is really, really important. But we also have new data on antithrombotic regimen because now we don't use anymore the aggressive one. So what can we do? This was your last question. Yes, Erik. So I don't know. I want to help you. I think, and this is for Tom, you don't have a lot of rugby in Belgium, but I wanted to show this one because I think, yes, in the task force, I've tried to reach out all the authors. I think you are the only one who is an implanter. So we count on you. We count on you to help us bringing the level at 1A, level of evidence A. Now, I'm sure that the results of Champion, Catalyst, and LAAC 4 are eagerly awaited by all the community and by the guidelines, for sure. And I'm afraid we will have to wait. I'm afraid. We don't have, I don't know about the time of the result, maybe Champion next year, or within 2 years. I'm afraid we have to wait. And I think that because we have to wait, we should take advantage of this time to prepare for the future, because it's absolutely not acceptable that we do 20 patients per year. So, it's like, because we don't have indications, we don't have a lot of patients, and because we don't have a lot of patients, we are not good with our skills. I speak in general, of course. And I think we should prepare for the future, because as you said, safety is what probably the most important data that we have to improve for the future. So stroke risk should be reassessed on a regular basis. Subclinical was silent and AF detection, I think it's something for the future. We like this. Oral anticoagulants, we know the limitations, I don't have to say more. And high-risk patients, I think LAAC 4 is addressing a new population, and it's very interesting. I don't talk about combined strategies, we will have a session on that. And I think that efficient and safe procedure to prevent stroke are really, really underused in Europe because of economical issues and probably unclear or misunderstood recommendations. I would encourage patients' preference, and I'm sure we should do that. The patients are not stupid. They understand what is a general anesthesia. They understand what is a bleeding risk. And I think we should rely on their opinion. And yes, we don't have a homogenized decision center in Europe, which is a pity, especially for this kind of situation. But we have to push, and that's part of the role of the club. Thank you.
Thank you, Philippe. We can certainly also discuss your perspectives. Claudia.
I like that, Philippe, actually, you touch a very sensitive nerve, which is the fact that most of the time the writers of the guidelines are not really an expert. And then here we have really an example. So there's a big struggle between the writers' guidelines, which are, most of the time behind the technology advancement and, what the physician and the expert on the field already are doing. So Tom was probably, one of the few. I don't know if there was even Prashanda Sanders in the list, very few, but the other, just probably not really compelled to, take into consideration, everything what you have already said.
Yes, I don't know what to answer. I think, yes, it was possibly unbalanced or not well balanced, but it's okay. I mean, we have to accept, as we know, all the evidence is not there, and we are waiting for that. And okay, the pity, as Jens-Erik said, is that we have to wait for 4 more years. Not we, but the patients have to wait. And for me, that's the main concern.
Yeah, I think you're right. And I mean, I don't completely agree with what you said. There is knowledge of the concept also in the task force. And there's also Prash and there's also Renate Schnabel, by the way. The thing is, at the end of the day, you vote on these issues. And this is what I tried to say earlier. The perception of LAA closure, I mean, in this room, we can all sit and be angry about how there's not a class 1 indication, but this is not the perception of LAA closure and the data backing this procedure in the community at large. And the thing we can do about that is raise awareness. The thing we can do about it is raise awareness and also be honest and say, yes, Jens-Erik, you showed you criticized the complication rates of historical approaches, which were there. We had procedures that, let's be honest, were perhaps not suited for mass implementation in the community at large. We do have much safer technologies, approaches now. We have safer devices now. Let's raise awareness about that. But for me, what is most interesting is the comment that Martin made on the difference in the US. I mean, the market has spoken there, but the driver is economical. The driver is not the data. The driver is economical. It's patients not willing, understandably, to pay $400 or $500 per month. It's probably not that much, but it's a significant amount for their drug therapy. And this problem does not exist in Europe, but we have other problems. Like you said, we have no centralized approach to healthcare in Europe. I fully agree with your statements on the lack of European policy or European decision centers.
So if we want to move forward and think about the consensus and I would say maybe study proposal or something, what do you think for lifetime management in AF? Should we just think about patients at high risk of bleeding or bleeders? Or should we start thinking about different populations? Should we implement patients who had a stroke despite NOACs, for example? Because we have enough evidence for these patients, or should we wait for LAOS 4 and other trials? Should we propose the procedure to non-adherent patients? What is a non-adherent patient? You have all these patients. I have. Some of them, they are really special patients that they, okay, no, I don't want this. Some of them, they really think that the drug is bad for themselves because they are sport practitioners, because they have an example of brain hemorrhage in the family, because, you know, they are not stupid. And the concept of non-adherence for me is something really important, because if you say to the patient, take a drug, he's not taking the drug. He's at very, very high risk. You have an option in your cath lab, but the system said no, not for this one. He has to take a drug.
Yeah, I think the solution to this largely is also, for me, I'm very happy to see you also put it on the slide, is to push this idea of appropriate rationale for alternatives. Because this covers a lot. This covers non-adherence, this covers stroke on anticoagulation. I think it is the way forward to change people's perception from a therapy that is a bailout therapy from people that are going to die from bleeding tomorrow, which is really, really very few patients, to a lot of patients where you say it's actually a sensible idea once you think about it. And I think it's the way forward in raising awareness.
And Philippe, I think that we have to move outside of our comfort zone, because we are still talking to people who are convinced that that procedure is working. So talking, doing, let's say, 4 sessions during EuroPCR will not increase the number of a procedure. We have to go out of our comfort zone, go to the general cardiologists, neurologists, gastroenterologists, and so on. It's not easy. We have to find the ways how to do it. That consensus clinical practice guide is one of the options, because only by that we are able to increase the number of procedures. But because here we can say, yeah, we all agree that procedures should be 2A, and we can start to cry, and we will wait another 4 years, but we have to go out of our, let's say, that group, trying to find patients somewhere else.
To be proactive, not only waiting. Xavi, do you have an idea for the topic?
Well, I like your point, and you know the fourth point that you were saying, that we will have to wait, but in the meantime we need to be prepared for this, catalyst and maybe like a big wave. So I think that probably it's true. I agree with him that we need just to open and go just to out of our comfort zone, but still, just to make that grow a little bit, like progressive, and make prepare the field for the best result. I think that it's also a very good idea. So that's why I think that these kind of meetings and all the rest are very important.
Maybe Lucas, last comment, or I mean, we can discuss as long as you all want. But
I was going to say that probably we have been fighting the anticoagulation companies and probably the mainstream of cardiologists in Europe and everywhere in the world that are used to giving these drugs. That's the easiest way to do stroke prevention. And so this is so ingrained in our DNA as cardiologists and physicians that you cannot fight that. Probably we are fighting it too much and we've been fighting it too much to give this to the patients that cannot take anticoagulation. And then you get into a whole this discussion with other cardiologists or physicians that believe in anticoagulation and that just do not want to see the disadvantage of anticoagulation. You will not win that. It's 90-10. Let's put it like that, percent of believers and non-believers. So you will not win that fight. Probably the trials that are going on now, where you combine it, and you're not fighting against anticoagulation, but like option, we are not fighting maybe against anticoagulation, or maybe LAAOS 4 is a good one, or LAAOS 3, we are not fighting anticoagulation. We're trying to find some way to live together. Otherwise, in 1 year from now, we have Champion, and then the Factor 11 drugs are also there, and then our healthcare insurance companies and the government is going to say, well, you have to wait now for another trial against Factor 11. This will go on and on and on and on, and then we will never have reimbursement if we keep on fighting drug companies.
Okay, so, yes?
I think we should have the proof of concept, randomized trial with closure versus nothing in patient, closure versus nothing in patient with real contraindication. This should be a proof of concept, and this is difficult, but this is the reality.
But this was what ASAP2 tried, of course, and I think it's a strong argument for a LA closure. It was unenrollable. Nobody wanted to be randomized.
Yes,
so
but for the guidelines, the randomized trial is this, because we have no trial in like that.
Just to add to that, so we finished the Closure F study with 1,000 patients in high-risk patients, and there was 2 therapies. One was NOAC or nothing, dependent on the physician's characterization of the patient's risk, versus LAAC. So that's basically that. There won't be a trial contraindicated patients because there are so few of them. And this is now the high risk, so basically all these patients that we basically implant, 500 and 500, and we will present hopefully at AC this year. So that will be the first big randomized trial.
Tom, maybe you should have a coffee, but I got one coffee question. So what, because in my place, electrophysiologists are interested now, they want to do procedures, actually training 2 of them. What's general take? You are busy enough, successful, all these beautiful energies ablating. Do you think more electrophysiologists will come on it and we be doing appendage closure? Because they are 50-50. operators currently? What do you think will be EP community doing about option and beyond?
My gut feeling would be that indeed option, and as a result of option, the concomitant strategy becoming perhaps more something that is considered, will increase EP interest. It's very intuitive. If you say we're going to do a combined procedure, well, yes, you're there already anyway. Companies like Boston, I'm sure Abbott is doing the same, are thinking about designing a single sheet that you don't even have to exchange the material anymore. You have a nice steerable sheet, it's there anyway. You do the ablation and you put the device. You see people in the US posting, I left an occluder on the way out. That's how they think about it, you know. You do the ablation and on the way out, let's leave an occluder there. So my gut feeling is yes, it will increase EP interest for the concomitant scenario.